Before I begin, I just want to comment that the FDA, the NCI, that's National Cancer Institute, and the National Institutes of Health, I think they are very aware of these problems. So there are initiatives in the National Cancer Institute that we need to sort of loosen our eligibility criteria, many of them around safety, but where we can kind of push those boundaries in kidney function and blood levels, like we were just hearing from Dr. Heath, I think they're trying to help us do that as long as we feel we can still keep people safe. But there's also another initiative that is new called Project Frontrunner. And so this is a way for us to move the treatments that we test in the most advanced disease states, which is kind of what you're talking about, back to earlier disease settings where people can have not be as sick when they ultimately get those treatments. There's been a tradition in the field where we have to essentially develop drugs in the cancer patients who have the most advanced cancer, and then little by little move them back earlier and earlier to people with less advanced disease. And so this project, this initiative recognizes that and is trying to do that. And so my hope is that that will, over time, try to be at least a first step in addressing this problem. But you're not alone. And to Dr. Heath's point, all of your doctors, at least the ones who participate in clinical trials, are right with you in trying to kind of think through how to best deal with this problem, which is not unique. And oxybutynin, if the Lupron or whatever you're taking is kind of giving you lots of hot flashes, ask your doctor about oxybutynin, which might be helpful. It's been helpful for some of my patients, but is a little outside of the box for prostate cancer. In any event, let's talk about advanced prostate cancer. This is sort of the more advanced setting, so we're going to talk mostly about metastatic disease and some of the updates that have happened in the last year or so. We'll start with prostate cancer background just to set the stage and kind of lay out the different disease states so we know which populations we're talking about. Then we'll talk about combination treatments for new metastatic prostate cancer. It may have been treated in the past with a prostatectomy or radiation, but now has come back. Or it might have been diagnosed with metastatic prostate cancer or prostate cancer that spread right from that first diagnosis. We'll talk about genetic testing, which I touched on earlier today, but we'll dig into that a little bit. And I think you have some education on that tomorrow as well. Then we'll talk about radioactive medicines, targeted radiopharmaceuticals. So infused radioactive medicine goes in through a vein and targets right to the area of the prostate cancer cell. And then a brief minute or two on survivorship, which is something that I think is important for all people living with prostate cancer. And then I'll wrap up at the end. So just to sort of set the stage, this is a slide that is really, really busy, and it continues to get busier and busier. What it's meant to represent is the progression of prostate cancer across the journey of that cancer. And it could be cured at some of the states on the left, but by the time we get to the right, and the orange boxes in particular, this is not going to be a cancer that we can cure. And so we need to work together to try to treat these cancer cells, try to get rid of as many of these cancer cells as possible, and help the person who's living with this disease feel as well as possible, knowing that, of course, we're going to help them live longer and hopefully better, but we can't cure the disease. This first part of the talk is really focusing on this middle section, which is the section of patients who have cancer that spreads outside of the prostate. And we do scans, and we can visualize where the cancer cells are, maybe in the bone, maybe in a lymph node, maybe in the lungs, but they are outside of the prostate, and we can see them on bone scans or CT scans. And this is called metastatic prostate cancer, or prostate cancer that has spread. We have this initial setting of metastatic prostate cancer in the setting where there's no hormonal treatment that's causing the testosterone to go very low. This is called androgen deprivation therapy. It's kind of the backbone of all of the treatments that we use for advanced prostate cancer, where we drive testosterone levels down really low so that we can starve the cancer cells of the food or the fuel that they need to energize them so that they can replicate, grow, spread, divide, and cause havoc. When we starve them by driving down testosterone levels, we can shut down their little factories and hopefully cause many of them to self-destruct. So this circle includes people with cancer that we can see on scans that has not yet been treated with that androgen deprivation therapy that really inactivates those cells. So it's basically metastatic, castrate sensitive, or hormone sensitive is its other term. So it hasn't had androgen deprivation therapy yet and become resistant. So this is another really busy slide. And the purpose of this slide is not for you to read all of these different trial names, because that would be crazy, but it's to emphasize that we have studied people with this kind of metastatic prostate cancer in many, many trials. And we've held them to the standards that we heard about earlier and had them go through 50 checkpoints of eligibility. And in each setting, we're trying to compare that standard androgen deprivation therapy, which in many cases is given by an injection in the backside or the belly or maybe the arm, and lasts for a couple of months. That standard androgen deprivation therapy has been pitted against combinations of that ADT, androgen deprivation therapy, and something else. And in every single situation, the combination of ADT and something else beats ADT alone. And this is really, really important. It's been proven in multiple clinical trials, as we can see here, but the combination of ADT and something else always wins over ADT alone. So this is a really important message for us to take home, that ADT plus something, maybe it's abiraterone, enzalutamide, apalutamide, radiation to the prostate in people with low volumes of metastatic disease. All these combinations are better than ADT alone. It helps people live longer and feel better, and these are two wins that we will take. So just know that ADT alone is not sufficient for metastatic prostate cancer, yet as we heard earlier today, about half of people in the United States are still getting ADT alone. That's not standard of care. That is insufficient unless they have a medical reason or a personal reason that they cannot or will not take a combination. So I just wanted to make sure we all know that. As we get into the rest of this talk, we're going to look at the data, the information that the clinical trial doctors and the clinicians look at when they're trying to make decisions about how do we talk about which treatments to combine maybe with ADT. And we'll talk about some of the newest data. This data is presented in what we call a survival curve. And these are not intuitive for people who do not look at these all day long. And so I wanted to talk it through to make sure that everybody is on the same page as we look at some of this information. And as you look at information in the future, hopefully this is helpful. These curves represent two different treatments. As you can see here, treatment A in blue, treatment B in red. And they are separated, as we can see across this curve setting on this figure. And importantly, time is represented on this figure as going from left to right. So as we go from the left side of this picture to the right side of the picture, time is moving on. And you can see that is measured in this particular figure in days, where we go from 0 days, baseline, to 1,000 days. And we can see what's happening to people in the two different treatment groups in the blue and the red lines. The number or the percent of people alive is listed on the vertical axis, the up and down axis, and closer to the top, more people are alive. So here we can see more people alive at the top, and especially as we get to the end of the treatment, we can see that there are people passing away along the way, and that happens in real life all the time to people, but in clinical trials as well. But the one with more people alive is always the line on the top. The space between these two curves shows the difference between the two treatments, and it shows that the one on the top, closer to the right-hand corner, is going to be the better treatment. So in this picture, treatment A in blue is the better treatment. And the space between the two curves is how much better treatment A is than treatment B. And we can see how that progresses from left to right over time from 0 to 1,000 days. So treatment A is better. So in all the curves we're going to look at, we're going to talk about the one on the upper right as being the better one. So just keep that in mind. Some of them show that the cancer is helping more people, or the treatment is helping more people be alive. Some of them show that that has more people alive with their cancer not growing. And we'll talk about which one is which as we look at these curves. So let's get into the data. We already mentioned that ADT on its own is not enough. So ADT combined with something else is really our standard of care. what the newest studies are looking at for these people with new metastatic prostate cancer that's hormone sensitive is whether we can use 3 treatments, so ADT plus 2 things, is that better than ADT and 1 thing? Because we need to build on not just ADT, because that alone is not enough, but ADT and something else. In this particular complex trial, we are showing what this is a schema. And schemas are the way that doctors understand how a clinical trial is delivering treatments and how they're following their people. So on the left-hand side of this slide, it describes the population of people with some of the key bullets that we heard earlier, that there could be 50 eligibility criteria, 50 things that you need to, boxes to check to get into a trial. In this, the key ones are listed here. So we see it has to be people with metastatic, hormone-sensitive prostate cancer, these new metastatic prostate cancers that have not been exposed to ADT yet. That's MHSPC, metastatic hormone-sensitive prostate cancer. They have to have metastatic disease, distant metastatic disease, and they have to not have had a lot of ADT before they get in. Those are the main things. And all these people with new metastatic prostate cancer were randomized. A coin was flipped and told them to go which group to go into, and there are 4 different groups. For the sake of ease of trying to understand this, essentially what these groups mean, and this, don't try to interpret the schema, it's a little bit complex. What they mean is people got standard of care, ADT, and actually chemotherapy, plus a pill called abiraterone or Zytiga, versus ADT and chemotherapy alone. And they were followed to see if the 3 treatments helped to control the cancer better than the 2 treatments, and also if people lived longer in one of the other arms. So here we are with a survival curve, and this is why I warned you. These are everywhere in our research. And what we can see here, this is the length of time for the cancer to grow. And remember, the treatment on the upper right side, the blue line in this figure, is the one that lengthens the time until the cancer grows better. And that is the triplet of ADT, chemotherapy, and abiraterone. It helps to control the cancer's growth longer than ADT and chemotherapy alone. And so this trial really showed us that it controls the cancer's growth longer for the 3 treatments versus the 2 treatments. And this is some of our newest data. It's called PEACE-1. It's a European trial. It also, the triplet, the 3 treatments, helps more people stay alive. And it helps prevent mortality or decrease death from prostate cancer when people got ADT, docetaxel, and abiraterone versus ADT and docetaxel alone. The 3 was better than the 2. There are some nuances here. These are going to be people with more aggressive prostate cancer in some cases. It's metastatic at the time of diagnosis, which means they didn't have a primary prostate cancer treatment back when they had it all in the prostate. And by virtue of the way that cancer came to light, we know that it's more aggressive because it was metastatic from the get-go. It never really was all in the prostate. So these are more aggressive cancers, but what this suggests is that more aggressive prostate cancer can be treated more effectively when we give 3 treatments instead of 2. But importantly, again, ADT alone is not on here because it's not enough. So this is just to show us, too, that those patients with the most amount of cancer, the highest volume of cancer, that's on the right, so the most spots on their scans, are really going to benefit more. They have more separation in those 2 curves than the ones with lower amounts of cancer. So this is just really more information to tell us more aggressive cancer, 3 treatments is better than 2 potentially, and something to talk to your doctor about because it may not be for everybody. The other trial that looked at 3 treatments versus 2 is ARASENS, and this one is looking at, again, this newly diagnosed metastatic prostate cancer patient population, and they used ADT chemotherapy and a medicine called darolutamide versus ADT and chemotherapy, and what they found is that the curve separated again, and the 3 is better than the 2. So ADT chemotherapy, darolutamide was better than ADT and chemotherapy alone. And again, ADT alone not on here. So again, 3 was better than 2. This is also a population that had more cancer for the most part and had this more aggressive form of prostate cancer for the most part. So still a question to ask your doctor, does this apply to me? But chemotherapy, ADT, and darolutamide, which is a hormonal agent, may be better than just ADT and chemotherapy alone. And this was true for people with, in this setting, people who had cancer that was metastatic from the time of diagnosis, but also for people who had cancer that came back after they treated their prostatectomy. But it looked most true for those people with the most spots of cancer on their imaging, so the most aggressive cancer. So this is one of our biggest updates. And just to remind everybody, this is just an example. This is not all quality of life data that's been presented in the last few years, but just an example that when we use more treatment and we better control the disease, we are often still helping people feel better, probably because we're controlling their cancer better. This is the quality of life data from something called the Latitude trial, which was looking at ADT and a pill called abiraterone. And people who had that ADT plus the pill had better quality of life than ADT alone. So again, it's beating ADT alone in this metastatic setting. And they had better quality of life, with the red line being up top, and that's in the better direction, than the blue direction, which is worse, ADT alone. So the conclusions for this newly diagnosed metastatic hormone-sensitive prostate cancer: consider triple therapy for patients who have more aggressive cancer, as long as they're fit for chemotherapy. At least have the conversation, and don't use ADT alone. That is really, really the bottom line. Sometimes we can add doublet combinations, ADT and a pill, sometimes ADT and radiation, and those are all conversations to have with your doctor, but not ADT alone. So the next section to look at and to think about is our metastatic castration-resistant prostate cancer. So these are patients with, we do scans, we can see spots of prostate cancer on the scans, but we know that these people have had that hormonal therapy in the past. They've had ADT, and now, even though their testosterone is low, the cancer is growing. So it's figured out how to grow despite that hormonal therapy. There are lots of things we can do here. This is partially because of all the clinical trials that people who have been in this audience potentially have participated in. Those trials run by Dr. Heath, those trials that I've been fortunate enough to put patients on. This has come from a lot of work. But all these colors and all these boxes represent a lot of clinical advances that have happened just in the last 10 years. And so really this is up here to show you, not to read every single box and to understand every little nuance, but to know we have a lot of treatments, even in this most advanced setting of metastatic prostate cancer. Part of those advances come from our understanding of genetics, mutations that can cause cancer cells to have that immortal quality, to be able to grow, divide, spread, and never die on time like they're supposed to. Nothing should live forever, especially not cancer cells, but these can. That's what makes them cancer. And when we look at these most advanced patients, we find that about 23% of them have mutations that might actually be targetable with some of the treatments that have been developed in the last few years. And that with each step along that path of metastatic castration-resistant prostate cancer we go, more and more of these patients will have these mutations that we can target with these special medicines. We know even that patients who just have new metastatic prostate cancer that has come back after they were treated maybe with a prostatectomy in the past, if they just have metastatic prostate cancer, about 11% of them, 12% of them will have these mutations. So it can even be in those people with just metastatic disease. And that's why anybody with metastatic prostate cancer is recommended to have genetic testing, germline or familial genetic testing. Just to emphasize what this is, and apologies for some of the formatting issues on the transfer from my Mac, it seems. Germline or familial genetic mutations are something that you get from your parents, 50% from your mom, 50% from your dad. You share them with your siblings and you share them with your children. Somatic mutations, which are on the right, are mutations that are only present in the tumor tissue. These only happen in the tumor tissue, can make that cancer cell an immortal cancer cell, can make it do and enact and behave like a cancer. Either of these mutation types can be targeted with our treatments, but we have to actually test for both in order to understand all of the options for an individual patient and for his cancer. These things are present, and we know they're present actually in levels that are pretty similar in each type of genetic testing. So in the tumor itself, somatic, or in the germline, the family type, and they're present in similar amounts for the most important or most prevalent genes, BRCA2, and then we can see different prevalence for the different gene types. But again, both need to be tested for in order to find what we can target. And this has been incorporated into our guidelines in the last few years, and is something we're continuing to educate doctors about and patients as well. And why is this so important? Because some of the medicines that we have newly approved for prostate cancer actually target these mutations. So one of these medicine types is called a PARP inhibitor. What is PARP? Well, let's start with DNA. DNA is the instruction manual for all cells. It's essentially the way that you build and drive a person. It is the instruction manual, the way that those cells are developed, the way they fit together in an organ or a tissue, and it's present in every single cell in the body. It is constantly being copied. It is constantly being copied so that new cells can be made. But there are constantly errors being made in this copy process. PARP proteins are normal proteins in our bodies, in our cells, that are supposed to be in there to fix all those errors and to make sure that when that DNA is passed on to the next cell, that it is not, there are no errors. But sometimes we can actually use medicines to interfere with those PARP proteins, block them from repairing the cell's DNA. And when we do that, the cell just builds up error after error after error. And when that happens enough, the cell self-destructs. So if we can stop the correction process, we can cause the cells to self-destruct. And we want that to happen in cancer cells that are building up errors that may give them new opportunities, new abilities to hurt people. So PARP inhibitors were tested in multiple clinical trials and reported in the last few years. So the PROfound trial was the first phase 3 or big clinical trial that led to the approval of one of our PARP inhibitors. And this, you can see this is a schema again. It includes the patient's type on the left. So these were patients with metastatic castration-resistant prostate cancer, a little bit more advanced prostate cancer than the last group we talked about. And these patients had all had actually a fair amount of treatment before. That ADT medicine that lowers testosterone, plus pills that further lower testosterone. And many of them had also had chemotherapy. All of the patients in this group, though, had those mutations that I mentioned earlier. They all had them either in their germline DNA or in their tumor tissue. And they were enrolled and they were put into their random buckets of which treatment to get. Some of those patients got olaparib, which is a PARP inhibitor, and some of the patients got an alternate pill than they had had in the past, either enzalutamide or abiraterone. Very, very good treatments for prostate cancer. And what this survival curve tells us, the curves separate. The blue one is the one on the upper side, and it's showing that it's a longer time for cancer to progress in patients receiving the blue treatment, which is olaparib in this situation, rather than that other AR targeting or hormonal type pill. And olaparib also improved survival, so it lengthened the time that people were alive with this metastatic prostate cancer. In the blue line, that's olaparib showing the better curve on these survival curves versus that other AR pill or hormonal pill. Rucaparib is another PARP inhibitor tested in a similar population, but all of these individuals, again, had those DNA repair mutations, but they also had received chemotherapy and these hormonal pills, and they were treated with rucaparib. And what we can see in these plots, these are called waterfall plots, all the lines going down below that baseline here is showing that on the left, tumor cells or the measured tumor deposits are shrinking. So these lines going down show the change in tumor size, all going down. And on the right, that's the PSA level, all going down. So this is showing us in people who have these mutations, and this was specifically BRCA1 and BRCA2 genetic mutations, tumors were shrinking and PSAs were going down. And everyone in this room, I think, knows that that means things were going in a good direction. Rucaparib was just tested in a big phase 3 trial with many, many, many patients, hundreds and hundreds of patients. And it also showed a benefit in this larger trial for patients when it was compared to those hormonal pills and also when it was compared to chemotherapy. And what we can see here is that rucaparib is represented by the blue lines in these curves, upper right, showing the better improvements in controlling the cancer's growth over time. So both of these PARP inhibitors are actually approved by the FDA as treatments that we can prescribe right now for patients with metastatic castration-resistant prostate cancer as long as they have these mutations in their cancer cells. And we're looking to see if we can give these to more people, maybe who don't have mutations over time. Clinical trials are looking into that. We don't know the answer yet, but it may be possible that more people will get these in the future, even that don't have those particular mutations. But these medicines are real, they're real medicines. They are medicines with side effects, and that should be that's important for every patient and every advocate to know too. They cause low blood counts, they can cause fatigue, sometimes some nausea or loss of appetite. And so they're not to be taken lightly, but they can make people feel better when used properly and when monitored and when we make sure that people are safe while they're taking them. I want to also mention pembrolizumab. This is an immunotherapy already approved for treatment of prostate cancer that has these special mutations, MSH and MLH mutations that I've listed here, or something called microsatellite instability high status. This is something that genetic testing identifies in the tumor tissue. And this is an immunotherapy that's already approved for prostate cancer. It can be helpful for maybe 2 to 3% of people with prostate cancer. So these are relatively rarer cancers. But what you can try to see on these CAT scans on the right, tumor tissues are much bigger, and when they respond, they can shrink a lot. And PSAs can go in from the thousands down to undetectable in some of the patients that I've treated who have these particular mutations and get pembrolizumab immunotherapy. So this can be relatively low burden, so not very toxic for most patients, but highly, highly effective when you have the right cancer cells in your body, and people can be very, very, very helped by this. Just to go through targeted radioactive medicines, this is a complicated slide too, but it's trying to show you that this little protein, which is listed in blue, or looks like it's in blue in that kind of pop-out box on the left side of this screen, that's a PSMA protein. We've heard that protein name mentioned several times during the talks today. This is a prostate-specific membrane antigen protein that many, many prostate cells put up like a little flag on their surface. And there's a special medicine, actually lots of medicines now, developed to recognize that protein. So when you get the medicine in through an IV, there are, in this case, a small molecule that finds that protein and avoids everything else, but finds that protein on those prostate cancer cells, latches on, and it gives a smart bomb directly to that cancer cell. In this case, it's lutetium. So this is lutetium PSMA 617, and this is lutetium 177, a radioactive molecule that is delivered directly onto the prostate cancer cell. And it kills it. When we find the right patient and we get these medicines to them, we can be really, really helpful. What these scans show is that we can also use special targeting agents that find that PSMA protein with PET scans now. And we can use that. And each of these panels shows a before and an after for some patients treated with this medicine, that we can see these areas where the prostate cancer cells are. And when the lutetium works for some patients, it can wipe out all those red spots. Now, this is not a cure. This is not a cure. I wish it were. And we'll see. Maybe in combination, and maybe when we use it earlier in the disease, we can use this in combinations to perhaps cure people. We don't know. But we are killing a lot of cancer cells and helping people. And this study helped us know that we can help people live longer with this medicine. So this study included patients with very advanced prostate cancer, metastatic castration-resistant prostate cancer. They'd all had chemotherapy. They'd all had hormonal pills. And they were given that lutetium PSMA 617 radioactive targeted medicine versus the best supportive care, because these patients had had basically every treatment available to them in most cases. And again, some more survival curves. What this is telling us is that patients actually lived longer. The curve on the left, they lived longer when they got lutetium PSMA 617, that's the blue line there, than when they got the best supportive care, which was really the best thing for them because the disease had been so advanced. So what I would say here is that treatment is really evolving rapidly. Genetic testing is really critical. It opens doors for lots of treatments and hopefully more treatments over time. It opens doors for clinical trials too. So keep that in mind because we have lots of targeted treatments being developed. We also know that these PSMA PET scans can help us by finding patients who have that little protein flag on their cell surface called PSMA. And this lutetium PSMA 617 has been approved and can be really helpful in helping people live longer. We're doing lots of clinical trials to look at this particular agent in other settings. And just a couple words on survivorship. Remember that ADT, even though, and it does have side effects and we've heard about them, it has hot flashes as issues, loss of libido, fatigue. It also causes medical complications, so keep that in mind for your loved ones or for yourselves. Make sure to know that it does affect cholesterol levels, it affects blood sugar levels, it causes people to gain weight around the middle, they lose their muscle mass. So we need to work together with primary care, with cardiologists, to really ensure that our hearts stay healthy, ensure that we stay fit, and ensure that we take care of the rest of ourselves while we're getting these treatments. The NCCN, which is a group that helps us as doctors understand how to best take care of people in a standardized way, has told us that we need to pay attention to these things. They give doctors a really clear guidance of how do we take care of blood pressure, cholesterol, diet and exercise, and it lays it all out for us. And certainly these are actually free guidelines for anyone in the audience. You just have to enter an email address, and so you can get these too, but it's important that we do have a list as doctors to figure it out. And recognize too that ADT thins bones. This is a fracture on that photograph there. It's actually, that's an x-ray. These fractures obviously don't just happen in women. Men get fractures too, and ADT thins the bones and causes this at a bit higher rate than you would normally see that. And so our NCCN guidelines tell us that anybody on ADT really should be thinking about calcium and vitamin D supplementation to try to keep our bones strong. The other thing that really helps is weight-bearing exercise, which is walking. We're bearing our own weight when we're walking, so it's all you gotta do, walk, and if you could do other stuff, that's great too, but do some walking at least, it's good for your heart as well. I also want to acknowledge, and this was mentioned earlier by Keith Crawford, depression is something that we see a lot in our cancer patients, and ADT actually increases rates of depression. About 40% of people at any given time will have an overlap of their cancer diagnosis with depression. And I think especially as we're coming through COVID, we're recognizing that we're not all healing the same from that experience. And if you're layering cancer or caregiving for someone with cancer on top of that, this may be something that's very near and dear to your heart. So this is something that we have treatments for, and our guidelines tell us to treat people, but we don't always ask. So if you're a caregiver or you're a patient and you feel like you might be helped by either counseling or medications, it's important to just say something because we can help. This is treatable. So metastatic prostate cancer is really complicated. Recognize, please, that ADT alone is not enough. We're undertreating about half of the men in the United States by giving them ADT alone, but we can do so much better in helping people live longer and feel better by giving them combination treatments. Genetic testing allows us to give PARP inhibitors, pembrolizumab, and potentially other medicines plus clinical trial opportunities to our patients. And we can now use things like radiopharmaceuticals, and we can target cancer that we can see on these new PSMA PET scans if they have that PSMA protein. Ultimately, diet, exercise, talking with your doctor, primary care, talking to each other is really important to maintain physical and mental health. And I think, as we all know, talking to each other as a community, to our loved ones, can be some of the biggest change that we need. So thank you so much for your time. No time for questions? Time for what? Okay. I have time for a question or two, if useful. Yes? Hi.
So I got a bunch of questions for you.
Great.
I'm sure you're surprised by that. You did answer my question about PARP treatments with no genetic mutations, but just to make sure I understood that correct, that if you do not have one of those mutated genes, PARP inhibitors, you don't qualify for PARP inhibitors now, but you think that in the future that could be something that progresses?
So that's a great question, and not a question that's easy to answer. So there have been multiple clinical trials that have reported out in the last year and a half looking at combinations of PARP inhibitors and hormonal pills, and looking at whether they lengthen the time until the cancer grows or spreads. And the combinations, for some of the combinations of PARP and hormonal pills, do seem to lengthen the time before the cancer grows or spreads versus those hormonal pills alone. However, there are a lot of caveats in that data, and that includes people without mutations. But that is something that we as a field are still investigating really, really aggressively, because it looks like it can be helpful potentially for people without alterations, but there are still some gray areas in our understanding of the biology that kind of is driving that, and in our understanding of the data from the trials, like the blood specimens and things are being, I think, looked at, and some of that data is still being reported out. So I'm hopeful that they might be used in people without alterations in combination with those hormonal pills, but I don't yet know, and actually nobody in the field knows, and it is definitely an area of hot debate.
So for people in my situation who are metastatic, stage 4, no genetic mutations, no family history, standard of care, Zytiga, Lupron, now Firmagon, and prednisone. As far as immunotherapy solutions, is that something that is an option for people in my cohort? And if it's not, then what else? Like, what are our options? Like, what's the compelling future for people at my stage, as well as far as like Lu PSMA? It seems like nobody wants to, or they're not allowed to put patients like me in that without these pre-qualifications of chemotherapy and ADT and all that. So I guess my question on the end of that one is, why? Is that just another bureaucratic holdup that's keeping that there, where it's just the squeakiest wheels that get the oil? Or is there something more to that? And then lastly, what is your opinion on bipolar androgen therapy? It wasn't mentioned in here. And there seems to be a lot of, at least within the patient community, of people really excited about that. I'm excited about it, but there's really not a lot of trials that are available to us right now with that. I wish we were able to do trials on our own. I think there's never going to be someone that cares more about our health than ourselves. And it seems like we're kind of handcuffed when we look at things like this. We're our own advocates. We do the research. We're not doctors. None of us are claiming to be, or researchers, but we know our body, we know our situation, and we know how the standard of care affects us more than anybody in the world. And the fact that we do not have access to things that we want to try. We want to give ourselves a trial. We want to try BAT, but we can't get testosterone, right? But what can we do? I mean, what can we do as patients, and what can you guys do as doctors to open that up, even if it's just for people that want to do holistic medication? There's no funding for that. There's nowhere to go. I came to ZERO, and I'm like, well, I need money for supplements and nutrition and everything else. And it's just, I understand it, but it seems like all of the focus is just on the pharmaceutical end. And there's no funding, there are trials with the other stuff. And I understand it's very complicated, it's hard to do double-blind, trials with food and nutrition, and that's a billion-dollar industry as well. But where do we go? Like guys that are in my position, where do we go from here? Thank you.
So I'll start with immunotherapy. So I don't know your personal situation, but Sipuleucel-T is another immunotherapy that is approved for metastatic castration-resistant prostate cancer. Pembrolizumab is really only for people who have germline or somatic mutations that demonstrate MSI high, TMB greater than or equal to 10, or there's a series of genetic alterations that are consistent with something called Lynch syndrome. And it sounds like you don't have any of those, and you've done both of the genetic testing types. So Sipuleucel-T may be an immunotherapy that you could try, but you would need to talk to your doctors because there are very specific criteria around who can get that, mostly related to if the cancer is slowly progressive or if it's quickly progressive and causing symptoms. Sipuleucel-T is only for people with really no symptoms or very few symptoms. So other than that, there's not an immunotherapy. There may be a trial, but there's no immunotherapy available at this time. Your second question was about lutetium PSMA 617, which I showed. So I really was showing today, there are so many, we've heard earlier, many clinical trials, lots of phase 2, lots of phase 1 data. I showed registration trials, so trials that have led to approval in the last few years. And so lutetium PSMA 617, or Pluvicto, is approved only at this time for people who have had ADT, docetaxel, and a hormonal pill. The reason for that is kind of what we were talking about in the last session, that we often test these treatments in people who are very near the end of their disease because those people have no other options. They've been through everything, and that's always where it starts, at least in prostate cancer. But there are programs in place now trying to move those success stories earlier on, as I mentioned. But there are multiple trials that have reached accrual. So the window has closed in terms of people getting on the trials, but there is one called PSMA-4 that is looking at lutetium PSMA 617 in people before chemo. We're hoping to see that data in the next 6 to 12 months, but we don't know. Hope is not necessarily the timeline of the trial, it's just what we hope. So there may be information that will allow people to give you that treatment earlier, but right now, we are not able to give that treatment earlier for multiple reasons. Certainly the approval is only in the most advanced setting, so we can't really just do that off-label. And one of the main reasons for that is the multidisciplinary team that needs to come together to give that treatment. So it's not just a regular infusion, it's not a pill, it's a radioactive infusion, so you have to kind of work together as multiple teams. You do need to get insurance approval, which is not typically going to be given on a medication that expensive off-label. And even bigger than that, there are supply chain issues and waiting lists. Even in the advanced setting, we have a waiting list, I don't know, 20, 30 people deep waiting for lutetium that already meet all the criteria for after chemo, after hormonal agent. And so those lists are very, very long, and there's just not enough drug to go around. So we're not able to just kind of give it off-label because there are a lot of people who already have gone through all these things and are still waiting for their chance. But the PSMA-4 data may change that for you because when that data comes out, it will help us understand, and a press release suggests that it can be helpful before chemo. And so hopefully you'll see that data soon and the label will change and the opportunities and the waiting list will change. When it comes to herbal medications, that's if there aren't trials, usually doctors are not prescribing things. There are some doctors who are holistic medicine doctors who might be able to help you, and if you are able to see some of those doctors at specialty holistic type places and use those kinds of advances and those kinds of strategies in combination with whatever you're doing with your doctor, I don't think most oncologists are not opposed to that unless there's concern for a medicine interaction, that they're giving you a medicine and the herb or the supplement that you're taking might interact. That might be a safety problem that they would worry about. But as long as you're open and honest, I think many of us are very happy to have that holistic and herbal supplement type of an approach in combination with whatever we're doing and support our patients to do that. And then when it comes to bipolar androgen therapies, there have been clinical trials. Most physicians do not feel, again, these have been small clinical trials, and they haven't proven that there is an absolute benefit. There's a suggestion of benefit in certain people without a knowledge and understanding of which people may benefit, and without a large clinical trial that suggests that there is a durable and lasting benefit with a safe profile of a way to safely deliver that. It's hard to really kind of get doctors all over the place to prescribe testosterone, especially because they know that for some patients that could cause a catastrophic event for their cancer. And so most doctors who don't have experience with bipolar androgen therapy don't feel comfortable just doing that off-label. I have not participated in the trials, and so I would be concerned that I would cause harm by prescribing testosterone to my patients, and so that would stop me from doing it. But there are doctors who have participated in those trials, and perhaps you could see one of them and get a consultation. Sometimes they feel comfortable after evaluating people to write out, this is how you might be able to do it safely, and if you had a doctor close to home who felt comfortable and confident with those plans, that may be an option. But it's a small group of doctors that really seems to be most comfortable with that, and those are the doctors that have participated in the trials. So hopefully that was helpful. Thank you. All right.